Kickstart the session today. The first topic is chemical injuries. I invite Dr. Dhanya V.S., Senior Associate Professor, Government Medical College, Ernakulam, to enlighten us on the same.
A warm good evening to one and all. My topic for today's discussion is chemical injuries. It is one of the true ophthalmic emergencies, and it is the only ocular condition where history taking and examination should be delayed, and our primary importance goes to removing the offending agent from the eyes. And if it is a bilateral chemical exposure, especially devastating, it results in complete visual disability. About the epidemiology, majority occurs in young males and majority occurs in the workplace, and more commonly by alkalis, and it is more commonly minor injuries, and in India it is common due to firecracker injuries, lime or accidental injury with holy colors. Chemical injuries of the eye, it needs an immediate and intense evaluation and management, and advancements in the ocular surface reconstruction has increased the visual prognosis, and this contributes to about 7.7 to 18% of all ocular traumas. Coming to the modes of the chemical injury, there can be domestic, agricultural accidents, chemical lab accidents, deliberate chemical attacks, chemical warfare injuries, and self-inflicted chemical injuries. And more into details of the alkali burns. These are the common alkalis which causes burns, and of this ammonia is the most harmful. And we should know in detail the mechanism of damage by alkali to know about the prognosis of the condition. Alkalis causes dissociation and saponify the fatty acids of the cell membrane, and this causes destruction of the cell membrane, and once it destroys, it enters into the cells and it is being hygroscopic, it absorbs the water and can result in total necrosis, and later they combine with the lipids of the cells to form soluble compounds. This in turn lead on to softening and gelatinization, and all these effects results in increased deeper penetration of the alkalis into the tissue. They spread widely and the action continues for days, and so the effect is difficult to circumscribe. Hence, the prognosis is very guarded in an alkali burns. About the acid burns, it is less serious than alkali, and these are the common acids, and of this hydrofluoric acid is most dangerous, and it is equivalent to alkali burns. And mechanism of action is totally different from the alkali, and it causes instant coagulation of all the proteins in the cells, and which in turn act as a barrier, thus preventing deeper penetration into the tissues, and these lesions are hence sharply demarcated. And chemical injury, the clinical features can be described in three stages: stage of acute ischemic necrosis, stage of reparation, and stage of complication. In acute ischemic necrosis, the conjunctiva shows necrosis, congestion, copious purulent discharge. Cornea shows widespread sloughing, edema, and stromal thickening or opalescence, and sometimes it can lead on to staphyloma, and iris shows violent inflammation. In the stage of reparation, conjunctival corneal epithelium will regenerate and shows corneal vascularization, and these are the complications in the stages like stage of complication, mostly in the lids like symblepharon, ankyloblepharon, ectropion, entropion, lag of thalamus, etc. And you can get complicated cataract and secondary glaucoma. These are a few pictures showing bilateral ectropion following a chemical injury, and entropion with symblepharon on the right side, and posterior and the anterior symblepharon, which is corrected by the amniotic membrane graft in the picture down. And you can see the joining together of the two lids, upper and the lower eyelids, medially in ankyloblepharon, and total corneal opacity with vascularization. And this is very important, the grading of the chemical burns, and depending upon this is the prognosis of the condition. And there are two types of classification. One is Roper-Hall classification, the other one is Duas classification. In Roper-Hall classification, mainly we are taking the amount of damage in the cornea as well as the limbal ischemia. And in grade 3, which is a guarded prognosis, there is total epithelial loss with stromal haze, and the iris details are obscured, and the limbal ischemia will be 1/3 to half. And in poor prognosis, according to Roper-Hall classification, the whole of the cornea is opaque and nothing is being seen, and more than half of the limbal ischemia is there. You can see the pictures for comparison. And next is the Duas classification, which is more specific about how many clock hours of limbal involvement is there. And here it is in guarded to poor prognosis about more than 9 to less than 12 clock hours of limbal involvement. And the conjunctival involvement is about more than 75 to less than 100. Very poor prognosis means almost 12 clock hours of limbal involvement is there, and more than 100% of conjunctival involvement. And based on this is the prognosis of the chemical burns. Clinical course is described in 4 phases. It can be immediate when the offending agent is immediately attacking the eye, and acute phase is the first week where the secondary glaucoma develops, and early reparative phase means in the first 7 to 20 days of injury, and late post reparative phase is after 21 days where you have to look for any persistent epithelial damage. And this is the most important, the chemical burns, how to treat a chemical burn. And the first thing you have to do is the prevention of the further damage. What all things you have to do for that? Immediate and thorough copious irrigation with available clean water or isotonic saline or ringer lactate. It should be with minimum of 2 liters of water over 30 minutes. If you have diphoterin available, which is a polyvalent amphoteric solution, which is hypertonic, which in turn reduces the corneal edema, this is of course preferred over the tap water, because tap water is not sterile and it is hypotonic because it increases the corneal edema. And the prognosis worsens if the irrigation is delayed, and do not waste time on history taking and examination. The first thing you have to do is the immediate and thorough copious irrigation. And next thing you have to do is a mechanical removal of the contaminant, and this especially if it is Lyme, you have to doubly wert the upper eyelid and look for it, and then you have to remove the trapped particles after putting local anesthesia. And debridement of the contaminated and the necrotic tissue has to be done to promote reepithelialization. The second most important thing is how to maintain favorable conditions to promote healing. These are all the drugs which you have to use for the chemical injuries, and I will be going into details about that. And topical antibiotic drops definitely to prevent secondary infection, and steroid eye drops usually given to reduce inflammation and anti-uveitis, and but it should not be given for more than 2 weeks as it interferes with collagen synthesis. Cycloplegic like atropine to reduce the inflammation, and also to relieve the spasm and to reduce inflammation. Ascorbic acid to promote collagen synthesis, and sodium citrate topical eye drops stabilizes neutrophils and reduce collagenase release. Preservative lubricants in plenty, autologous serum which provides growth factors and also promote healing. And you have to prevent the formation of the symblepharon by sweeping a glass rod smeared with ointment twice daily in the upper and the lower fornices. Acute phase management, topical steroids inhibit the reepithelialization, so frequency have to be decreased after 1 week, or you have to switch on to progestational steroids or medroxyprogesterone, which reduces the effect on the stromal repair. About the new advances in the management, which contains plenty of growth factors to promote epithelialization, you can use 20% of autologous serum, umbilical cord serum, then platelet-rich plasma and amniotic membrane. And late reparative phase treatment, if the injured eye has achieved intact epithelium by 21st day, as I told you, there is significant risk of permanent visual loss. And this needs surgical intervention like debridement, conjunctival advancement, alloslat, tissue adhesives, amniotic membrane graft, and therapeutic keratoplasty. And a few points about the amniotic membrane transplant. This is very good for grade 2 and grade 3 Roper Hall, but in more advanced chemical injuries, it is of not much use. Alloslat is limbal stem transplantation usually done in acute phase. Advantage is huge amount of stem cells obtained and promotes reepithelialization. So in Roper Hall grades 5 and 6, you have to combine the amniotic membrane transplant as well as alloslat. About the management of the secula, if there is a persistent epithelial defect, you have to do a Tennant's advancements first, and over that you have to do an amniotic membrane transplantation. And this is a simple flow chart about the limbal stem cell deficiency, is very important. You look for whether it is a unilateral or bilateral. If it is unilateral, whether it is partial or total. If it is partial, then you have to give amniotic membrane graft, debridement, and conjunctival limbal autograft. And total means slet, CLAL, and KLAL. And bilateral is cultured cadaveric allograft. And KLAL is keratolimbal allograft. And Boston K-Pro and Comet is cultivated oral mucosal epithelial transplant. Treatment of complications, poor corneal healing, amniotic membrane transplantation, pseudopterygium excision with limbal graft, corneal opacity, keratoplasty should be delayed more than 6 months to allow the inflammation to subside, and in a severely damaged eye you have to do a keratoprosthesis. So the take home message is, it is a true ophthalmic emergency. Thorough wash has to be done when you come across a patient in the casualty, and only then you have to take proper history and assessment, and prognostication by based on the classification of Roper Hall and Dua's classification and treat properly. Steroids being the mainstay of treatment for controlling the inflammation, and game changer is the limbal stem cell transplantation, which brings more of stem cells and growth factors, which promotes good epithelialization and healing. Thank you.